Hello everyone and welcome back to my channel. So today's topic is adenocarcinoma of the colon. Now this is a very important topic because you can see that there are multiple mechanisms or molecular mechanisms of this pathogenesis. There are very subtle differences between these three mechanisms. There are actually three mechanisms and all of these three have got distinct differences. So this is my attempt to break down this particular topic for you. So without further ado, let's get started with this discussion. Now, adenocarcinoma of the colon is the most common malignancy of GI tract and is a major cause of morbidity and mortality. Now, just to share with you that this particular disease or cancer is something which has got a very important meaning in my life. I have a very emotional story to share regarding this particular cancer. So I'll be doing that in some other video. And this is my thesis topic also because I'm so close to this particular topic that okay, we'll discuss it in some other video. So today we are just going to talk about the molecular mechanism, very important. Now I've already mentioned this in one of my previous video that if there is an increase in the protein intake along with decrease in fiber, then that will lead to colon cancer. If your diet is consisting of an increased amount of protein and decreased amount of fiber, then that will ultimately has got a risk for developing colon carcinoma. It is theorized that reduced fiber content leads to decreased stool bulk and altered composition of the intestinal microbiota, which gives rise to this particular cancer. And now aspirin and other NSAIDs have a protective effect, important. COX-2 is necessary for the production of prostaglandin, which promotes epithelial proliferation, particularly after injury. TLR4, which recognizes lipopolysaccharide and is also overexpressed in adenomas and carcinomas, upregulating the COX-2 expression. Now, yes, from here the interesting part starts. At least two genetic pathways have been described. Number one is the APC beta catenin pathway, which is activated in the classic adenoma carcinoma sequence. So we have one pathway which is the APC beta catenin pathway, which is the actual adenoma carcinoma sequence. Now you know that first there's adenoma and then from there you have this carcinoma. So this is basically the major kind of the most common pathway. So this is one. Number two is the DNA mismatch repair and accumulation of mutations in the MSI pathway. So number two is the macrosatellite repeat region, MSI pathway. So these are the two main pathways, but there is also a third mechanism, and that is where the confusion starts. So I'm going to take you through each of these in detail. I'll first come to my notes and tell you this basic understanding that one number is the ABC beta catenin pathway, the number two is MSI pathway, and number three is the this one. So let me first clarify with you that what do you mean by beta catenin? Now there is a gene which is known as the APC gene. The normal functioning of APC gene produces APC protein. And what is this function of APC protein? APC protein degrades the beta catenin. Okay. Now, beta catenin is something which is responsible for the growth, for the uncontrolled growth of the colonic epithelium cells. So it is the beta catenin which is the culprit. Very important. Beta catenin is the culprit, but beta catenin itself is not mutated here. Here the APC gene is mutated, and we know that APC kind of degrades the beta catenin. So now if the APC is mutated, so APC protein will not be able to degrade this beta catenin. So the level or the amount of beta catenin will increase, and this will lead to more uncontrolled growth of the colonic epithelial cells. This is how this carcinoma occurs. Okay. So I will just repeat this once more that beta catenin is the main culprit. Its function is to promote growth and proliferation of colonic epithelium cells by the WNT signaling pathway. And we know that APC is a gene or APC protein. Its normal function is to degrade the beta catenin. This is what happens normally. But when there is a mutation or epigenetic alteration, that leads to inactivation of APC, and now this will no more be able to degrade the beta catenin, and now this beta catenin level will be increasing. It will accumulate. This will stimulate the MYC or the cyclin D, which will ultimately cause uncontrolled growth and proliferation of colonic epithelial cells. So this is the first gene which is the most important, and that is why this name is APC beta catenin pathway. Number 2 is KRAS activation. Number 3 is SMAD2 and 4. These are the different kind of genes which are involved in this pathway. SMAD2 and 4 is a tumor suppressor gene. So once there is a kind of mutation in this gene, therefore there will be an increase in the activity of the cell cycle. Now this SMAD2 and 4, basically it is a tumor suppressor gene. It stimulates the TGF beta pathway, which causes a decrease in the cell cycle, which will stop the cell cycle. It inhibits the cell cycle. So SMAD2 and 4 is a tumor suppressor gene because it inhibits the cell cycle through the TGF beta pathway. But once there is mutation, this TGF beta will no more be there. So now there is a decrease in the TGF beta, so this will be ultimately increasing, means ultimately there will be an increase in the activity of the cell cycle, which will ultimately cause increase in the proliferation and unrestrained cell growth, right? So I hope that you are understanding this mechanism. So yes, number 4 is the TP53. There is loss of function of the TP53. Telomerase activity is increasing, and the beta catenin mutations. In some examples you may get beta catenin mutations, but usually this beta catenin mutation is not happening here. Here what happens is that there is mutation in the APC gene. Okay. Now another important MCQ here is that chromosomal instability is a hallmark of APC beta catenin pathway. This is a very important point to note, because this can be asked as questions that APC beta catenin pathway में hallmark क्या है? That is a chromosomal instability. Now if we come to the second pathway, which is the MSI pathway, this is basically the DNA mismatch repair deficiency. Okay, now mutations accumulate in the microsatellite repeat regions, and therefore these tumors are known as MSI high or MSI H tumors. So MSI high or MSI H tumors means there is mutations in the microsatellite region repeats. There is a defect in the DNA mismatch repair. Okay, now there are certain factors which are there in this microsatellite repeats. Number 1 is the type 2 TGF beta receptor. ठीक है, तो microsatellite repeat में these two things are present. Number 1 is the type 2 TGF beta receptor, and number 2 is the BAX, which is a pro-apoptotic protein. Now when these mutations are there in the microsatellite region, which means that mutations are happening in these two regions, because this region is containing these two factors. Now if there is mutation in the microsatellite region, so these two factors will now be mutated. Now normally this TGF beta 2 receptor, what is the function? Its function is to encode the type 2 TGF beta receptor, and I've already explained over here what is the function of TGF beta. It inhibits the cell cycle, means it is tumor suppressive. It doesn't cause tumor. So TGF beta is good. It will inhibit the cell proliferation. So here it was there normally kind of activated, but now when there's a mutation in this particular region, in this particular receptor, so now this TGF beta will again not be produced. So again that will not kind of inhibit the cell cycle. So not inhibit cell cycle means ultimately there will be an increase in the cell cycle. नेगेटिव नेगेटिव पॉजिटिव हो जाता है, तो मतलब अभी जो कि है uncontrolled cell growth होगा. I hope that you are able to understand this. I'll just repeat this once more, that there are two receptors or factors in microsatellite repeat region, and in this particular MSI pathway there is mutations in the microsatellite repeats. So in the microsatellite repeat region, if you have two factors, now because of these mutations these two factors are mutated. And what are the two factors? TGF beta receptor type 2. The main function of this normally was to produce TGF beta type 2 receptor, which kind of inhibited the cell cycle normally. But now when there is mutation in this receptor, there will no more be production of this TGF beta, and now there is uncontrolled cell growth. Okay, and similarly loss of BAX will lead to enhanced survival of the abnormal clones, because BAX was a pro-apoptotic protein. It enhanced apoptosis, but now when there is a loss of BAX, that will enhance the survival of these abnormal cells. Okay, So this is basically the second pathway. And now what is the third pathway? Third pathway is a subset of microsatellite unstable colon carcinoma. So this is microsatellite unstable, okay, without mutations in the DNA mismatch repair gene. Previously what we saw in that particular pathway, there was defective, mismatch repair, but here there is no defect in the mismatch, or there is no mutations in the DNA mismatch repair. Here what happens is there is CpG island hypermethylation phenotype, which is known as the CIMP. So this is the third pathway in which you have this hypermethylation ka phenotype, which is the CpG island known as CIMP. What exactly happens here is that there is hypermethylation of the promoter region of the MLH1 gene, reducing the MLH1 expression and repair functions. So MLH1 basically had repair functions, but now when there is hypermethylation, what is the exact meaning of the word hypermethylation? It means silencing. ठीक है, so hypermethylation का मतलब ही है silencing. So when there is hypermethylation or silencing of this MLH gene, now this expression will be reduced, and therefore the repair functions will no more be there, and therefore there will be an increased proliferation of cells and carcinoma. So this is basically the CIMP phenotype. Now along with this, we can also have mutations in the oncogene BRAF. KRAS and TP53 mutations are not present in this particular pathway. Combination of MSI plus BRAF mutation plus methylation of specific targets such as MLH1. This is basically the summary of this process. I will repeat this once more, obviously, because I know that a lot of points you haven't yet understood. So the differences is what is the most important. That is what is highlighted for the MCQs. So I will just mention very important point that in this particular pathway, what was happening, APC gene was getting mutated and beta catenin pathway was increasing. Okay, what was happening in this pathway is that there is number one DNA mismatch repair deficiency, which means there's a defect in the mismatch repair process. So this was happening in MSI pathway. Number one point. Number two point is that there are mutations in the macrosatellite repeats. There is microsatellite instability present in this pathway. This pathway means MSI pathway means microsatellite instability हो रहा है यहाँ पर, ठीक है. Another important thing is that in this particular pathway, you have the KRAS activation and the TP53 activation. So you have mutations in this particular genes here as well. Okay, but what are the distinct features of the third pathway, which is the CIMP or the CpG island hypermethylation phenotype? Here what was happening, here MSI is positive, means here you do have microsatellite instability, but this is a subset of the MSI pathway, means here you do have MSI positive, you do have microsatellite instability, but along with that, what's more important here is the CpG hypermethylation. This is something which is not present in the previous two pathways. So here the specific point is that you do have CpG hypermethylation, which is known as the CIMP, and here there is silencing or hypermethylation of the MLH1 gene. A very important point. You also do have mutations in the BRAF gene, but very important here, the KRAS and TP53 are not mutated. These two were mutated in the first pathway, in the APC wala pathway. In this pathway, these two are not mutated. So this differentiates it from the earlier pathway. So therefore, we can say as a summary that combination of MSI plus BRAF mutation positive, methylation of some targets of MLH1 gene, all these three things will point to this particular process, which is the CIMP or hypermethylation wala pathway. So I have taught you three mechanisms. Number one is the beta catenin APC pathway, number two is the MSI pathway, number three is the CIMP pathway. Okay, now there is also a fourth pathway. इसके बारे में मैंने पहले नहीं बताया क्योंकि otherwise you would have got completely confused. Now just separate this pathway from the other pathways. So this is number 4 pathway. What happens here is there is no MSI. Here there is absence of microsatellite instability, but there is hypermethylation going on over here. So in this pathway we saw that MSI was positive, along with that hypermethylation was also positive. तो यहाँ पर both are positive, but यहाँ पर MSI is absent but hypermethylation is positive. So I have written it over here that MSI is negative, but hypermethylation of the CpG islands is positive. And very important, you do not have BRAF mutation over here. Here you are having BRAF mutation. There were mutations in the BRAF, but the KRAS and TP53 was not mutated. Here just the opposite. Here you do have KRAS mutations, but you do not have BRAF or TP53 mutations. And KRAS was absent in the earlier and present over here. So these are the subtle differences from the earlier pathway. There is no names of this pathway, but you need to know this entire 4 mechanisms. And if you're asked, you have to kind of write this, but please pay attention more to the number 1 and number 2 pathway. MCQs will be asked from number 1 and number 2 mainly, and also to some extent from this particular pathway. This one is not that important, okay? Now some basic points. What is the most common site of the metastasis of the colorectal carcinoma? It is the liver. Number 2, what is the morphology of this? These are tall columnar cells with strong desmoplastic stromal reaction, which ultimately gives the characteristic firm consistency of these cancers. Okay, this is the morphology. Now another important point is that beta catenin gene is never mutated. Here I have shown you that in some instances, in some very few percentage, that can happen, but usually the beta catenin gene is not mutated in colon cancer. Here rather the APC is mutated, which increases the beta catenin protein, which increases the transcription factors and the growth of the cells. Now beta catenin gene is actually mutated where? Actually mutated in the hepatocellular carcinoma and the hepatoblastoma. Okay, so these are some of the important points. I'll just take you through this very important image. So as you can see, there are two pathways. This was the APC beta catenin pathway. So basically there's first hit in which you have this APC gene mutated, followed by a second hit in which you have these methylation abnormalities and inactivation of the second alleles, which when accompanied by some proton coding mutations, like for example in the KRAS, that will further be accompanied by this homozygous loss of additional cancer suppressor genes, overexpression of the COX2, and all these genes are involved, which is mutated ultimately, and that leads to adenoma. Adenoma के बाद further additional mutations and chromosomal alterations will give rise to cancer. Okay, now this is the second pathway, which is the mismatch repair pathway. So in the normal colon, you have the first hit. Similarly, you have the second hit by the help of mutations in these genes, which will ultimately lead to a microsatellite instability mutated phenotype, which further when exaggerated by mutations in all these genes will ultimately lead to carcinoma. And here the precursor is a sessile ciliated adenoma. I have already mentioned these points in the chapter of polyps, in where I told you about the adenoma, which is the precursor for malignancy, and this one is the sessile ciliated adenoma, which is neoplastic, which ultimately leads to cancer, and this was plain adenoma. Okay, so all these points I have discussed, and now just coming to this morphology. It is distributed approximately over the entire length of the colon. The proximal colon often grow as polypoid exophytic mass, and in the distal colon you have these annular lesions which produce these napkin ring constrictions. And now you please tell me that what is the clinical features from the right colon and the left colon. So in the right colon and the cecum, you have this fatigue and weakness due to iron deficiency anemia. So iron deficiency anemia is a presentation in the right sided colonic cancers, but in the left sided colonic cancers you have changes in the bowel habits. So you have vocal bleeding, you have changes in the bowel habit and or cramping, and left lower quadrant discomfort. So you have to understand that the iron deficiency anemia in a older man or a post-menopausal woman is GI cancer unless proven otherwise, because obviously in a post-menopausal woman, she is not having blood loss every month, so then how will the anemia develop? So in a older man or a post-menopausal woman, if there is iron deficiency anemia, that should raise the suspicion of cancer, GI cancer. Very important points. Now the two most important prognostic factors are the depth of invasion and the presence of lymph node metastasis. Okay, so if I can just show you this is well differentiated. You can see this elongated hyperchromatic nuclei over here, and necrotic debris are also present. This is the poorly differentiated carcinoma. There are very few glands, as you can see over here, and this is the basically mucinous type of carcinoma, where you can see this signet ring type of cells and this extracellular mucin pools. Okay, now this is also important, this TNM classification. T1 is invading into submucosa, T2 is muscularis propria, T3 is muscularis propria into the pericolorectal tissue, and T4 is invading into the adjacent organs. So I hope you enjoyed watching this video. I will come up very soon with the next episode. I will appreciate your feedback for this video. If you like my content, then please consider subscribing, and take care, keep studying, and thank you for watching.